This is Health Wealth Safe. We believe everyone is entitled to high-quality, inexpensive healthcare. What started as one doctor's dream to bring the control of healthcare back into the patient's hand has now turned into a partnership of independent physicians across the country, all working hard every single day to make this dream a reality for their patients. Together, we will unlock a healthier world. That's the power of Health Wealth Safe.
How are you today?
I'm good.
It's so good to see you, and it's such a pleasure. You're doing so wonderfully. I am Dr. MJ Collier, host, producer, and on-air personality for the Your Health is Important radio broadcast. I'm also in private medical practice in Lithia Springs, Georgia. The name of my practice is Atlanta West Primary Care. I was introduced to the concept of my remote checkup by Dr. Agarwal, whose practice is in Athens, Georgia. The concept had been presented to me multiple times, but no one had done it as eloquently as Dr. Agarwal did. That inspired me to partner with him and to start and initiate this into my practice. Now, I know we signed you up for the My Remote Checkup program, and they have really been good in monitoring certain disease states. So what do you think about that program?
I really like it. It provides a lot of information for me and it helps me to keep up with my numbers. So it's really good.
My Remote Checkup has been an absolute godsend. This allows them to feel we are actively involved in their care continuously, and we are. And it also just gives them a sense of home and camaraderie with the practice. I think my practice probably has about 5,000 to 6,000 patients in it. And being in constant contact with that many people is beyond my capability. But in partnering with My Remote Checkup has been a great concept and a great follow-through, so to speak. It's really done well for the patients. And as you can see, one of the things that has changed since we have been on that program, the numbers are markedly improved. I mean, we are really doing phenomenally well. And I think that program, because it's reaching out and touching you on a regular basis and keeping you actively involved in your healthcare process. So to have a good outcome, you have to have the right patient and the right provider, and you have to form a partnership. And I think that our partnership, along with the remote patient monitoring program, really is going to be the thing that's helped changing your healthcare. I've been doing on-air radio for 30 plus years. So that gave me an opportunity to meet a lot of people, and that's what you see on what I call my wall of fame. In that, I've had an opportunity to meet politicians, social activists. I've met a lot of entertainers, and that is just a continuation of the pictures that I have in my home. Patients love those pictures, and it sparks a lot of conversation. And patients say, how did you go? Where did you meet? And where were you when you were with Denzel Washington? Or where were you when you were doing the boxing? When patients feel as if you're actively involved in their care, they feel as if they know you. They feel as if you are part of the family, so to speak. They respond better. They listen to you. They do most of the things you ask them to do. And they live longer and healthier lives. So My Remote Checkup has allowed us to reach out and touch far beyond our capabilities, as if I was personally on the phone all day, every day. I am Dr. MJ Collier. The practice is Atlanta West Primary Care Associates. Reach me on all social media platforms at Ask Dr. MJ, and listen to me as a medical consultant on the Ricky Smiley Morning Show.
The U.S. healthcare system is facing a lot of challenges, especially when it comes to medical waste. There are almost 14 million Americans with 3 or more chronic conditions that require frequent medical attention. As this population continues to grow, how can we best support these individuals in a dignified and cost-effective way? Introducing Health Wealth Safe, a proven healthcare technology company focused on reducing cost while increasing the quality of care for everyone. At Health Wealth Safe, we use our FDA-approved devices through bidirectional communication with our care managers and physicians. Our devices work remotely to passively monitor your activities of daily living. With the Health Wealth Safe app, you are able to keep track of activities such as sleeping, water intake, medication, and so much more. We promote patient health and can also detect early changes in health, such as physiological and non-physiological data, which results in early management of the illness and prevent hospitalization. When a significant change in behaviors is detected, an alert will be generated to our team of highly qualified care managers. The care management team will then reach out to you, and if needed, we will refer patients to their own physician. This also cuts down on medical waste that is created with testing or imaging that you may have already had in the past. Health Wealth Safe wants to help change the way the medical industry works by providing timely, affordable treatment where you can actually see the results. This will lead to a lower overall cost of healthcare and more satisfied patients. Our app not only helps you keep track of activities and medication, but you can also store all of your medical records in one place. We believe that you should be in control of who gets to see your information. If you decide to simply share your information with a loved one or a caregiver, they just have to download the Health Wealth Safe app. You asked for a better way to do healthcare, and we heard you. Let's do healthcare the way it should be done.
I'm Dr. Bantwal S. Palika. I'm an endocrinologist. My office is called the East Alabama Endocrinology PC. We have a website also. And I have another office in Columbus, Georgia. Then I have satellite offices in LaGrange, Georgia, and Athens, Georgia. We use all these technologies to do what is called the remote patient monitoring. For example, we have partnered with Dr. Subodh Agarwal. He has a program called Health Wealth Safe. It's an app on the phone. And this is a very good tool for me to keep an eye on a lot of my patients, what we call as a population health control. It is not enough to see patient one time in the office or see them once in 3 or 4 months, because things can go horribly wrong in between. So the idea is to remotely monitor these patients' blood sugars when they are at home, and the data gets sent to us over the internet, and we have an access. We have point people who keep an eye on all these patients, and I get notification if there are issues. For example, somebody having repeated hypoglycemic episode, somebody is having blood sugars of 400 and 500 all the time. So Health Wealth Safe is one of the best ways for me to do this population control and keep an eye on all my problematic patients who need more assistance. Now this will help our patients not to go to the ER, because we are trying to save money for Medicare and other insurance companies. Because if a severe hypoglycemia happens and if the patient has to go to the emergency room, that means about $10,000 to the insurance companies. So that's why the remote patient monitoring comes into play. I'm very happy because I have a huge population of patients, and as a single physician, I'm unable to keep an eye on them all the time. That's why when Dr. Subodh Agarwal approached me with this health wealth save, it was a welcome idea for me. It was an easy adoption. Dr. Agarwal has assembled a great team of people who manage this whole program. They call the patients and they give them enough information. They inform me as and when necessary. They create notes, and overall, we try to keep our patients safe. And patients are also very happy saying that, yes, Dr. Baliga is keeping an eye on me. So that's an additional layer of security.
One of the presidents of Morehouse School of Medicine once said that all children should know their grandparents. I chose the name, as I said, this is my practice, and family first. You know, putting family first and then their health. So providing patients the health care that they need in a family fashion. My name is David Blake. I'm a family medicine physician. My practice is Family First Healthcare in Lithia Springs, Georgia. In family medicine, we're trying to practice preventive medicine, taking care of patients' disease processes and preventing them from having problems with those or even developing them in the first place. So my remote checkup helps to do just that by checking in on the patient in between visits. Typically, you see a patient once a year at minimum, and then depending upon their diseases, every 6 months or every 3 months. So there's always going to be a time frame when there's no direct contact between the physician and the patient, but you still need to know what's happening with their blood pressure readings and their blood sugar readings. And this is a way that they can be checked on remotely. And some of our older patients don't really have a lot of family members or friends calling them, talking with them. So now they develop that relationship because the navigator from my remote checkup calls that person consecutively. They don't go from one to another. It's always the same person. They develop a relationship and they get somebody calling them and looking in on them. The patients actually enjoy the app because, one, they can contact the office. No matter how many telephone lines, how many people you have working them, there's always going to be somebody that has to wait. So this is a way that the patients can contact the office after hours, even during the busy office hour days, and get their information to me as necessary. If there's a problem, it gets brought to my attention, and I can adjust their medication, advise them to come in, or get them to where they may need to be. I have patients that are Spanish speaking. So now in the office, I do speak Spanish, but the rest of my staff does not. But we can get them a navigator who can speak to them in their native language, and they can more comfortably communicate their needs to the office. Some of my older patients, when they come back in for their first visit of the year, they have no knowledge of my remote checkup. So I get a chance to explain that to them. I let them know that that's now part of our practice. It's a means for me to keep up with them. And in years past, I had to give them pieces of paper to check their blood sugars on and write it down and write their blood pressures down.
I was just writing down everything, and sometimes I'll forget to have a pencil in my hand when I finish my blood pressure, or I'll forget what it was, or I used to take pictures of it with my phone, then my phone will lock out, so it's like, golly. But when I got the device, it made it easier, is because the results go straight to the doctor's office or to whoever's watching it, and it goes to the doctor. So, yeah, I'm very pleased with that. I'm glad that Dr. Blake chose my remote checkup. It has really saved me and my mind, so now I don't have to worry about writing down anything. You get just what you want, and I got just what I want.
My remote checkup is physician-run, so it's somebody who understands the process of the medical office and taking care of patients. And my billings personnel, they're supervising the daily records anyway through the EHR, so they're able to see if there's anything going on that should not be. And so far, there's been no conflicts, no errors, and everybody has been happy with the process. Unless you really want to commit dedicated staff members to enrolling the patient, asking the questions, and then documenting the billing procedure, I found it has worked better to go ahead and let the My Remote Checkup personnel handle that. They're skilled in it. They have been doing it prior to my knowledge of the program. They know the codes to use. They know which billers will and will not allow it to be used, and therefore they can go ahead and get the bills cleanly through and then turn around and do the reimbursement and reconciliations each month. And I have not thus far had any issues with that. And getting used to using the app myself, so far it has been fine. I have an opportunity to go into the app. I can find patients. I can see what their escalations are. I can see what their recent readings have been, and can communicate back with the patient directly from the app. That way it's not disclosing my personal information after hours, and they can still get the follow-up that they need in a timely fashion. Again, I'm Dr. David Blake, Medical Director of Family First Healthcare. I can be reached at 770-948-5400.
Welcome to Remote Diabetic Management Webinar. This is one of the webinars we have done. We have done several other in past, and you welcome to watch them on YouTube. Let me introduce myself. I'm Subodh Agrawal. I'm a cardiologist in Athens, and I'm blessed with the company of Dr. Vendwal Suresh Baliga. He's a internationally famed endocrinologist and traveled from India, England, and New York, and currently practicing in Georgia, Alabama, and has office in Athens, LaGrange, Columbus, and Opelika, Alabama. Dr. Baliga has seen diabetes from very early time when the diagnosis was done with the checking the urine and smelling the urine. So Dr. Baliga, you have seen almost all phases of diabetes.
Yes.
And tell us what kind of problem we are facing in diabetic management.
Yeah, so thank you, Subodh, for inviting me today. It's great to be here. So, and it's nice studio here, and you look great, yeah, we saw so many patients with diabetes today, and you see the challenge, right? And when I look at my patients with diabetes, they're almost like my own children, right? I know that they're in trouble. My job is to keep them safe. And diabetes is such a terrible disease because the end results are really bad, right? People can lose eyesight, they can damage their kidneys, lose their feet, have a heart attack or a stroke. So those are the challenges that we come across. But if you really look at it, over the past several decades, I remember seeing patients in India. For some reason, this clicker is not moving forward. Just go. So patients used to. Why this is not moving? Right.
Well, Chesko working on it. Dr. Yes. Baliga practice in Athens. He comes all the way from Columbus once a month. And if you have a complicated diabetes and you are on insulin pump, you are on continuous glucose monitor, and your diabetes not being controlled, please call us, and we can help you with that.
Yes. So these are all the challenges we come across, right? Because if you really look at the way we practiced in India a long time back, patients used to come to the office with a urine sample, right? Then we used to put 8 drops of urine in the Benedict solution and boil it on a Bunsen burner and see how the color changes. According to the color change, we say blood sugar is plus 100, plus 200, plus 300. So then we used to ask patients, okay, when you go to bed, how many times you have to get up in the middle of the night. So if they wake up 3-4 times, that means it's a poor glycemic control. Whereas they go to bed and they wake up in the morning, there's a good glycemic control. It used to be very simple, right? But now the management has become so complicated because for the first time ever, we understand diabetes like never before. We understand all the pathophysiology. Not only that, we have all the different designer drugs to take care of each of these problems. But despite that, what about the access to the care? A lot of patients cannot get these medications. The cost is most of the time is prohibitive. And education, right? We need to educate because we want to empower patients by giving them more knowledge, then they can manage their sugars much better. And some of them need really personalized care, individual care. It's not like a cookie cutter care for all. So it's a different thing, Then there are barriers, there are technological issues, but there are certain barriers that we have to deal with. Then there are mental health challenges. So that's why we have to fight for our patients.
So let me ask you a question, Dr. Baliga. So how bad is the problem? I mean, in America, we have population of 300 million.
Yes.
So how many people affected? Are they started from childhood? Tell us about a little bit about that.
Yes. Again, there are only two. Somebody was joking. There are only 2 kinds of Americans: those who have diabetes now, others who will become diabetic later. So it's like almost everybody is likely to be diabetic. So as you can see, we have about like 38 million patients with diabetes, but 3 times that of them they have pre-diabetes. And even a 1/5 of diabetics, known diabetics, but they don't know that they have diabetes. That's why it's scary, right? And we spend an enormous amount of money. Even if you look at the data from 2017, $327 billion to fight this disease.
So looking at this, when do you think first time mother or of a child or adult, like I'm 20-year-old, when I need to think about, do I have a diabetes? Do I need to go to my doctor? When do we screen for diabetes first?
Yes, so everything depends upon, for example, African Americans, Asians like us, Hispanic Latinos, Pacific Islanders, Native Americans, they have a much higher risk of diabetes. So they need to be screened much earlier. Now, if there is a strong family history of type 2 diabetes or even type 1 diabetes, the kids need to be watched very closely. So our recommendation is you look at the child, and most of the time their BMI or even their belly will warn us in that something is not right. So we see a lot of youngsters coming, their moms bring them to our office. They're young, they're 8, 10 years old. In the old days, at that age, type 1 diabetes used to be very common. But now we see kids with too much of weight issues, and they're more likely to have type 2 diabetes.
So let me ask you, you saw a patient bringing urine to your lab, and you deciding how much insulin to give. There was insulin that time.
Yes,
right?
yes.
So now you see advanced technology. My God, we now almost have artificial pancreas. Tell us about the journey from that time to here.
Yes, so this is one of the old, I think probably 1930s and 40s, state-of-the-art urine testing technology. I still have that in mint condition. So this is where the journey started, right? If you really look at it, all the credit goes to Banting and Best. So they were the ones who first discovered insulin in Toronto, in Dr. McLeod's lab. So when they got the Nobel Prize, so it was given to Banting and McLeod because he was the professor, although he didn't have much to do. So basically it was a work from Banting and Best. But Banting was a gentleman. He actually shared half the money, prize money, with his friend Best. So, but they were so noble, they didn't even patent the insulin. And they wanted it to be free, so that they realized that this has a potential to transform society, save countless human beings. So they were very passionate about it. They were very noble about it. So if you really look at it, so nowadays we talk about all this closed loop insulin pump, right? Where you have a pump on one side, a sensor on the other side, they talk to each other and keep your sugar under good control, what you call as a closed loop. But in 1963, they developed this big pump, like a backpack, but that had the capacity to check your blood sugar, and depending upon the blood sugar, there was an analyzer inside that big box. And there was an algorithm built in which will recommend, okay, this is how much insulin needs to be given. 1963, although it wasn't that accurate, right? Then the idea was to how to get it to the masses, right? Because the concept of doing the finger sticks, it happened recently in the 1980s. Before that, it was only urine test. So again, in 1970, you saw that Amy's reflectance meter. That was the first portable blood glucose meter developed and patented by Anton H. Clemens. So there was a needle which moved when you put a drop of blood in that paper, and depending upon the light reflections, it can tell you what kind of blood sugar the patient is having.
When the finger stick came up?
So I think it came in about 1987 when you
not
got,
too long.
Not too long ago. So that's why So I'm sorry, we're still having problem in advancing the slides. Yes. So okay. So this is okay. Let me go back. Yes, this one. So you look at that. It's called biostat. So it was meant for hospital use in the 1970s by the bedside. And this machine will check the blood sugar and recommend how much insulin to be given. So this is one of the first, what you call as a closed loop insulin.
So I was in medical school that time. I have no idea what's going on.
Yes, because it was only in some specialized institutions. It was not common in every ICU. Then actually, then somebody developed auto syringes where they can deliver precise doses of units or mLs. So this was a great achievement. You know, Dean came in 1976, so he developed that machine. Okay, so this is the glucomander. Have you heard about glucomander? Probably not. So again, this is a bedside machine. This is a FDA-approved algorithm, and it is of great use in patients with the diabetic ketoacidosis in the ICU setting, because that will look at the fingerstick glucose every few minutes, and it will alter the rate of infusion of insulin. So it's very expensive. Not everybody can afford it. Some of the hospitals are still using it. So I think we can do much better than this one with the available technology. Then the next, down there you see that Medtronic's Minimed, the CGM. This is the first continuous glucose monitoring system. I was in Mount Sinai at that time. I used this one.
Oh, really?
Yeah, you put it on the patient, they go home, come back after 3 days, it will record all your blood sugar. But they had to do, for calibration purposes, they had to do some finger sticks. Then we download the data and look at the glycemic excursion. Worked reasonably good. Not very accurate according to the current standards. And see, look at the journey of how the whole technology evolved. From urine testing, then we went on these sensing technologies, the biosensors and implantable sensors, you name it. But if you look at 1987, that was the first time you got the home glucose monitors.
That's what everybody using now.
Yes,
So that's awesome.
Then in 1999, they came up with a Glucowatch. So it was not a blood test. It was a process called iontophoresis, where it tested the sugar in the sweating. And it was not very popular. It used to give like a weak current, so it was not very comfortable. So, but now since then we have these implantable sensors like Eversense, and we have these. If you look at the first sensor that came into the market after Medtronic was Dexcom. It used to call Dexcom STS. Then the Abbott Freestyle Navigator came. Then the Medtronic iPro. We used a lot of iPro in the office setting. So the first iPro, patients will come, we put that iPro sensor in, they go home, come back after 3 days, we download it. It was a blind. Patient doesn't know what's happening. But it was a great tool. And we did a lot of stuff with the Medtronic's iPro.
So almost everybody wants to use this sensor now.
Yes. And again, 2018, the Eversense. So remember, you came to my office in 2018 in Columbus. I was the first one to insert Eversense.
So you love technology. I have seen that.
I like it.
You use all kind of technology in your office.
The reason is I know that patients are all very busy. They do not listen to us. They got a life to lead. And the way I see it, technology is going to save us all. And that's why I'm always in the constant lookout for technology which is affordable and which can be used in an office setting, which can be used in the home setting. And the idea is to give patients knowledge, and knowledge is power, right? If they know a blood sugar, what's going to happen when they wake up in the morning, or when they eat a meal, when they go to bed, when they get up in the middle of the night. So if they do know their numbers, then they change their lifestyle. Subconsciously, they know that, if you eat a big bagel and you see the sugar going up in your sensor, when it crosses 180, they're like, wow, what did I eat?
I mean, this is amazing that the sensor change your life.
It changes life.
You know which food you should eat and which food you should not eat.
Correct, So we went over it again soon. Yeah, so
tell us about the new technology and how you're using it.
Yes. Okay. So there are so many things that we use, right? We use all finger sticks, different kinds of machines. We use the sensors. We use the pumps. We have got standalone pumps. Then we have the pumps which talk to the glucose sensor, what you call as a closed loop pumps. So we got everything, for type 1s and type 2s or an insulin. So the idea is you start somewhere and get the patients get used to these technologies, and slowly advance it according to their needs. And it all depends upon their insurance coverage also sometimes. Because all said and done, I can write any kind of pump I want, any kind of sensor. Is it covered in their insurance plan? Okay, is the copay, is it affordable? See, those are the challenges that we have to look at. But I'm glad that as we speak today, we got enough technology to help our patients. Now the idea is to how, let's say you are my patient, okay, do you need a continuous glucose sensor? If the answer is yes, then you have to figure out which one is ideal for you.
But I want it because it's really going to change me. So
correct.
So
yes, if you want it, then half the battle is won.
Yeah.
Then we have to fight with the insurance company.
Oh yes.
See, that's the. But you know, insurance companies are opening up because they see the value. Because what's the whole idea? You know, if we keep patients safe, healthier, then they're less likely to go to the ER or get hospitalized. Once they go to the ER, it's a lot of money for the insurance company. Once they get hospitalized, a lot of money to the insurance company. So can we use all these insulin sensing technologies, insulin delivery systems? Can we keep our patients safe?
So
and
Dr. Paliga, let me ask you,
go?
can you tell me or just give some idea that have we improved the care of diabetes, the people using sensor versus not using sensor?
Yes, definitely, because just using the sensor, studies have shown that your hemoglobin A1C will come down by about 0.6 to 0.8%. Just using the sensor, same medication, all right? But you use the sensor technology with the pumps and other, for example, Bigfoot Unity device, then you see A1C drop about like 2, 3, 4%. That's a powerful thing. That's why we see that within a couple of weeks, because we see the data before we start the patients on a particular device. Then when they come back in 2 to 4 weeks, when they download, like, wow.
Very good.
Yes. So this is the way the sensors work. There's a small needle.
This is the difference between the finger stick, you checking the blood, and here you don't check blood, you check the tissue.
Yes. So when you do the finger stick, you get capillary blood sugar. Okay. But when you insert a sensor, it's sensing glucose in the interstitial fluid. Okay. And there is a reaction happening in that needle, glucose oxidase, that converts into milligrams of per deciliter of glucose. That's the broad way of looking at it. Now, this is the advantage of using the sensor, right? If I ask you to do a finger stick, you will do 1 time, 2 times, 3, 4 times. Sometimes sugars look good. You look at the green dots, right? They are all in the normal range. But the same patient, if I put them on a continuous glucose monitoring system, then we download, then see, these are all the things that we missed.
Yeah, those green dots say that breakfast, dinner, and snack,
yes,
everything look good.
Look good, but you know, see what happens in between. All these glycemic excursions we miss. That's the reason it's better to have a sensor.
So tell us about the current CGM and pump system.
Yes.
I know it will be complex. We don't want very detailed.
Yes.
Just tell us
right.
which patient need what and
yes.
what's the advantage, disadvantage.
So most of these sensors that we use Abbott Freestyle Libre 2 and the latest Libre 3 and Dexcom G6 and now G7. That's one of our very favorite sensors to use. Eversense is my passion. You know, I was the first in the country to insert it. We have some challenges because it needs some surgical procedures. Insurance coverage was not great. Now we have Medicare coverage, so it's likely to see more use of Eversense. Then you have Medtronic's Guardian sensor also.
So Eversense, you just need 2 sensors per year.
Yes, it's when it launched, it used to be once in 90 days. Now it's like once in 6 months. It's so easy, right? You come to my office, you put the sensor in. It's a very small surgical procedure, 5 minutes. That's it. You come after 6 months, we take it out, put a new one in. Right?
That is great.
And not only that, I can watch their numbers from my office. Patients are at home, but we can remotely monitor. So all these sensors, the Libres and the Dexcoms and Medtronic sensors, we can remotely monitor them. So then when you come to the pump, you know, there are like some simple pumps. I like Vigo. Okay, it's a patch pump from Mankind. So I use it a lot. A lot of my patients, it's like basically it's like a wearable patch You change it every 24 hours. So it gives a small amount of insulin throughout the day and night. There's a button. Let's say we are talking to each other. Without you knowing, I can click through my cloth and give myself insulin.
So before lunch, before
Before
dinner,
lunch, before
bolus.
dinner.
That is incredible.
Yes, yes. Then we have Tandem. They have a beautiful pump. It's a touch screen, and that works with the Dexcom G6. They have what you call it, control IQ algorithm, and all this artificial intelligence based system. They can read your sugar 30 minutes to 60 minutes ahead of anything changes. See, that's the beauty. It's not that just what we are seeing now. We know what our patients are going to do in the next 60 minutes.
So in children, who manage these pumps?
So again, depending upon their age, but usually moms and dads, they are involved. But as the kids get older, they become very adept. We train them, and they are very safe, very smart kids. They can do that. But usually mom or dad keeps an eye on them. So then we have the Medtronic's MiniMed 670G, which was the first closed-loop hybrid pump. I never thought I would see this day in my entire lifetime. And FDA worked with the Medtronics.
Tell for audience, what is closed loop and open loop?
Open loop is, in the old days, you had a pump on one side, and either you do the finger stick and you do a sensor, but you have to tell the pump what's the blood sugar. So that means they have to type in, looking at the glucose numbers, then you have to put it in the pump, and the pump will calculate, and it will ask you, okay, it looks like per my calculation you need 6 point units. Should I give it? Then you press yes. Then it will give. So that is in between there is a person, okay? In the closed loop, the idea is to get the middleman out, the patient out. The idea is to, the pump on one side, the sensor on one side, they talk to each other. They keep on adjusting the sugar. If the blood sugar goes up, pump will give you more insulin.
So they're connected wirelessly.
Wirelessly.
So the sensor connected wirelessly with the pump, and then pump decide how much insulin you need to give.
Correct.
And the sensor tell us where we are with the sugar.
Correct.
So that is awesome.
Correct. And if the sugar goes too low, it will stop giving insulin. Say, for example, you're in the middle of the night, you're hard asleep, and in the old days, you go so low, you wake up with a seizure.
So if I need insulin to control my diabetes, I need that pump.
Yes,
right?
that makes very, very. It's good to have this technology to help you, so that you can have a better night's sleep, and the whole idea is to prevent hypoglycemia. I do not like hypoglycemia in my patients. A little bit of high blood sugar I can live with, because hypoglycemia kills. That's the reason I like all these pumps, because even that Omnipod Dash and Omnipod 5, that's the latest pump, they talk to the Dexcom. And today we saw like 3-4 patients, they do so well. See, that's the thing, all these pumps that I use, when they come to my office, we download and we see how things are doing. And we have to make some minor adjustment, but more and more as the technology evolves, it becomes less onerous for a physician like me to get involved with my patient care.
So tell us about give us a little taste of this.
Yes, so this is a Freestyle Libre 2, like a coin-like patch. So you wear it, you change it every 14 days. Then there's a reader in the blue. And if you can see, you see that number 112. That means currently this person's blood sugar is 112. Then you look at the arrow mark very next to that. But what does the arrow show? It's pointing upwards. That means in the next 30 to 40 minutes, the blood sugar is going to go up. So I tell my patients, watch the arrow. And in that, the whole screen, you can see the last 8 hours of blood sugar also, right? And in the old days, you had to swipe it, but with the newer technology, you have a phone app, and it keeps on getting updated every minute by the minute. See, that's the advantage of Freestyle Libre.
So it is almost like Dexcom, right?
Yeah, with the Dexcom also similar capacity, but Dexcom data gets upgraded every 5 minutes.
Okay.
Still good, very good, yeah. Then every 2 weeks you change it. That's the inserter at the top, and this is how it looks. You wear it on the back of the hand, and you won't even know you have it, right? And that's why it's one of the more popular sensors. And we use Freestyle Libre 2 with this device called Bigfoot Unity device. So basically you see that algorithm in the handheld your phone, then you use the Freestyle Libre. Then if you look at that white pen cap, so let's say your patient is on Humalog or Novolog. So you take the original cap off, then the company will give you electronic cap. The white cap is a reader also. So if you bring that reader close to the sensor, it reads your glucose. Then there is a button, you press it, it will tell you how much insulin to give. And not only that, when the person takes the cap off, give the insulin, we, in the system, we have this clinic hub, we can see. And we can look at the compliance. Let's say you come and tell me that, oh, I'm taking all my insulin chart. And I look at the hub, if I see the marks, I know that you're giving it. If I don't see it, that means you missed those shots. That's why it improves the compliance.
Does improve compliance?
It improves compliance a lot. So the black pen cap is for a long-acting insulin like Tresiba. So, and this is the latest one, the Freestyle Libre 3, much smaller sensor. Again, you know, every 14 days it gives you another additional half extra day. And just there's
Libre
one.
3, you still have to bring the phone next to the Libre?
You don't have to bring it close.
Okay.
It automatically, because there is a Bluetooth, so it automatically shows you the numbers. So this is how it looks, much smaller. And we have something called Libre View. So you can use these sensors for population health management, like what you're doing with the remote patient monitoring. Let's say if you have like 100 patients on Libre, you can watch all of them on your clinic hub. If a patient calls you, I pull up the chart, I click on it, and I see this what you call as a AGP report. So this is one of the beautiful things we do with the Libre. Then Dexcom, this is another favorite of ours. So most commonly we use Dexcom G6, but recently they brought in Dexcom G7. So you change it every 10 days. And one of the advantages with the Dexcom G6 is they interact with the T-Slim pump and with the Omnipod pump also. And there's a newer pump coming down the road. I think they're also going to use Dexcom. So it needs you have to put it in the abdomen, and there is a 2-hour warm-up period once you get it.
So Omnipod, if I have Omnipod, I cannot use Libre.
Yeah,
Then
no
it
point.
will
Yeah,
be
it's
open loop. If you want a closed loop, you have to have a Dexcom.
at the moment.
Okay.
Yes. So this is how it looks. You can use the phone also. Now this is the G7, and which is much smaller than the G6 and much more economical, and only one Surrogate. So this is getting probably, this will give the run for the money for Libre now. So, but it's good. Competition is good. So you get better and better, and within 30 minutes you can see your readings. And now you can put it on the back of the arm also. And for the patients, they have this Dexcom Clarity app on the phone, and it tells them all their story, what happened today, what percentage of the time you are in the normal range, how many lows, and what time of the day is good for you, and what happened in the last 1 week, 2 weeks. So patients can really learn about their diabetes. And so easy, just one inserter, and they can do their normal activity. They can swim, they can dance, they can take a shower, and we have Dexcom Clarity app. So this is our clinic hub. Again, all our patients, they're all connected, and if they call me, even in the middle of the night, I click on this one, and I know what's happening. So I can tell my patient how to manage their diabetes much better. See, in the old days, it's just guesstimating, right? Oh, what was your blood sugar? What was the finger stick? Obviously, patients are not doing too many. They will give you a couple of points. Not really that helpful. So that's why you need the sensors. And this is the Eversense. See how small it is. You've seen the sensor, right?
This is the
it's
one
like a
you
matchstick.
put under the skin.
That is the Eversense, yes. So
This is the
now
one,
it
two
used to be
sensor a month.
it used to be every 3 months. Now every 6 months we change it. And the black one is the transmitter, which is the power source, because the sensor itself, it doesn't have power. So it needs power, right? The transmitter, which sits on top of it, it gives power. Then it sends back the readings. It gets converted into milligrams per deciliter. Then you see the glucose readings in the phone. And we can watch it And it has something called on-body vibration. If your blood sugar drops below 70, you feel the buzzing noise. If the blood sugar goes above 280,
So I
you
saw
feel the
some
buzzing
picture
noise.
with a girl. Show me that. Tell me the story about this.
Yes, so,
Yes.
right, okay, on the right side, that was Kathleen Peters. So she was the one who came to me with the Eversense. She was very high up in Eversense universe, and she persuaded me to start using this technology. And she was instrumental, so, and the patient on the right side, she is my patient. She was one of the first ones to go on the Eversense.
So you put Columbus on the diabetic map.
Yes, that's the thing I'm telling you. In the old days, we waited for all these new technologies to happen in New York and Los Angeles, and ultimately, after a couple of years, it trickles down here. But now I'm like, no. We are as good as any other people. Our patients are real patients. They need the best technology available. So I fight for them. I bring all this new technology so that they can adopt it, they can lead a better life, live longer possibly. So, and this is the Medtronic's Guardian Connect. I use it some, but not that much. So, but I use a lot of Medtronic's insulin pumps. So again, it's all connected. Patient's family can watch it just like Dexcom G6 and G7. With the Dexcom G6, I do the follow function also. Remember one of your relatives in India?
Yeah, tell me about that story. Tell the audience the story.
Yeah, so that's great. A few months ago, remember your nephew? He came from Bombay, so he was a very busy doctor in India. He comes for a wedding, his blood sugar was like 400 and 500. So you panicked. You flew and you called me. I said, take Dexcom G6 with you. So we put him on the Dexcom G6. Then I could watch him using the follow function from Columbus. And we helped him a lot. We changed his therapy. Even now I watch him. He's on my phone and he's around 120, 130 all the time.
So he's in Delhi or Amroha in India, and they're almost like 5,000 miles away from here. So his data go to the server, and then you can see it here.
Correct.
It's amazing.
It's amazing.
So you basically can treat all over the world.
Yes,
right?
it's theoretically, yes.
As long as they have sensor.
Correct. I need to make sure that I see that number. So
yeah.
So let's
tell us about the pumps.
Yeah, pumps. So this is one of the easy pumps that I use. There are no electronic components. It's just driven by the spring mechanism. So it takes only one kind of short-acting insulin. So it has a basal rate where it gives you small units of insulin throughout the day, just like your pancreas does. And mealtime, there's a button, and let's say you have to take 4 units. Each time they press the button, it gives them 2 units. So if you have to give 4 units, you click twice. If you have to give 6 units, you click 3 times.
So you can adjust according to the large meal, small meal, breakfast.
Correct.
Yeah, that's very nice.
Yes, it's very easy. And I got about like 1,000 patients on that, and they all love it. So, and only thing is, it doesn't talk to other sensors. That's the drawback. So, but see how it is. It's easy. You won't even know that you're wearing it. So, and more affordable probably, and easy to train. And this is the T-Slim pump. Again, this is one of the beautiful pumps in the market. It's a touch screen. Okay, it talks to the Dexcom. And again, you can see your numbers in the last 8 hours. And it uses a technology called Control IQ. So this is a AI-based algorithm. So it can look at the rate of rise or rate of drop in the blood sugar. And it can warn us 60 minutes ahead where your sugar is going to be. And that's why, when you use these technologies between the Dexcom and the T-Slim using the Control IQ, we want our patients to have reasonably good control throughout the day and night.
So what are the chances of a patient having hypoglycemia?
Correct. So if the chances are less, because what happens if the blood sugar drops, say, below 70, and the sensor will tell the pump, and pump will stop giving you insulin.
Very nice.
Then what happens? Instead of sugar go lower and lower, now it starts coming up. Once it comes up to 100, then the insulin pump starts again. So it's like driving a Tesla car, right?
So, there's a misnomer about patient. I need to eat because I need to take insulin. And then what happened when you do that? Then what happened? You continue gain weight and you continue to take more insulin.
Correct. So we tell them to.
Does the pump help that?
Correct.
Lose weight?
I'm not. Theoretically, yes, in the sense, if the patients are under good control, they don't need too much insulin. Because if you inject insulin, sometimes you inject double the amount of insulin that you need. More insulin means more weight gain. So we've seen when patients who are taking 3-4 shots of insulin, when we put them on insulin pumps, their insulin requirement comes down by about 50 to 60%.
And does that answer the weight loss starting?
They can lose some weight.
Some weight. Very
So
good.
again, weight loss depends upon so many other issues
Of
also.
course,
So,
of
yes.
course.
Yes. So this is how the kids can use it, and beautiful pump. And if you're going for a swim, you can.
So this pump
it's
has a needle,
waterproof.
is that right?
Yes, these are all with the
Tubes.
with the tubings. Okay. So this is the first closed loop pump.
So when you're taking a bath, do you take it out?
Yeah, you can. There is a quick insert, or you can take it out, and you can take a shower and put it back again. So it's easy. So this is the first one in the market about like 5-6 years ago. It was 670G, but now they have 770G. Again, it talks to its own sensor, and they talk to each other and keep your sugar under good control. And this is the 770G. Now they're going to stop manufacturing any more 670G because they don't see the reason, because they're coming up with the 780G. So see, the thing is, with each new pump which comes into the market, technologically they are much superior than what they did in the past. But most of the problem is the sensor technology. If you have a good sensor, if you have a reliable sensor, if there's something called MARD, if the MARD is 7 or 8, that's a much more accurate sensor. So we need sensors with the MARD lower and lower. So that's why now the latest one is the Dexcom G7. MARD is supposed to be like in the 7s.
That's awesome.
So, yes.
The MARD, just tell audience.
Yeah, it's
what
called
MARD
mean
is.
absolute relative difference.
So how accurate the system
Correct.
is.
Let's say if I do a finger stick, or if I look at sensor reading at the same time, how close they are.
Correct.
Okay. So that's why if the MARD is like 10 or 12, it's not very reliable. If the MARD is around 8 or below, much more reliable. So this is how it looks, so easy. And this is the new kid on the block. This is the Omnipod. They used to have Omnipod Dash. Now they have the latest with Omnipod 5, which works with the Dexcom G6. And they talk to each other, and there's an algorithm built in, Smart Adjust. And it keeps on looking at the sugar trend going up or down, and accordingly the pod will give you either extra insulin or less insulin, or sometimes even pausing the insulin. The data gets updated every 5 minutes. So this is beautiful. It works. So we saw like 3 patients on Omnipod 5 today, and they were all doing pretty good. So easy. So youngsters sort of love, because this doesn't have a tubing, and the tubing sometimes becomes too messy. They like the patch pumps.
So let me ask you a few things. If I take insulin, 1 shot a day, or maybe 2 shots a day, and I spend some kind of money, when I start using the pump, how big my bill becomes?
It depends upon the insurance coverage. So
No, insurance, somebody has to pay.
Pay, yes.
So we're looking for a high quality, low cost. So cost, whether insurance pay or some government pay or you pay, but somebody has to pay, right?
The cash price for a pump would be about 5,000 to 6,000.
For
The
per month?
initial cost.
Per
Initial
month?
cost.
Okay.
Then after that, there are supplies, the insulin, the sensor. So, some patients have very good insurance, and about 90% of the cost is absorbed by the insurance company. Some people end up spending more money, but the way I look at it, if they are getting a good glycemic control with almost no low blood sugar, spending some money is worth it. Because what's the whole idea? Get you to goal with little fuss, without hypoglycemia, without needing to go to the ER or hospital, without having any accidents. So that will save so much money for the pump company and for the patient also.
So what's the future of diabetic management?
Yes, so this is, I'm very excited, in the next few weeks, I hope that FDA is going to approve this one. It's called bionic pancreas or islet. So this is still in development, but basically they have done all the clinical trials and all the data in front of the FDA. And as soon as the FDA says, okay, this is a safe pump, then they are going to release into the market. So basically it uses Dexcom for the sensor input. And the idea is to have both insulin and glucagon in the same pump. That's why ultimately when
so the insulin bring the sugar down and glucagon bring the
correct.
sugar up.
When the blood sugar drops, when it reaches a hypoglycemic range, the previous pump, they will stop giving insulin. Then the next thing you know, the sugar goes up. Instead, it will give you a small bolus of glucagon to raise the sugar a little bit high. So it's like a tandem between insulin and the glucagon. They tend to keep the sugar in good range. The first version which is going to get approved is only with the insulin. It does not have glucagon. That's why they won't get bionic pancreas designation. It will be one of the closed loop pump. But the second version of the pump, they will, they're waiting for the FDA again to give its blessing. So with this pump, it's so simple. You wear the pump and it learns your glucose. It learns your eating pattern. You don't have to put anything. Okay, all you have to announce means press a button saying that I'm eating. And the pump will look at the rise in glucose as you keep on eating and keeps on giving more insulin to bring it down.
So are the European using this?
No. This is a pure American
American,
product.
okay.
Yeah, most of the time it comes from Europe, but this was done in Boston, in Harvard University. So really, I've seen the preliminary data when I went to the ADA, and looks good. And hopefully, see, this is what we need. And as we advance, every year we get better and better technology. And ultimately, my hope is that patients will put one of these pumps on, they forget about everything. Maybe the same pump will have sensor also. So that's my dream. So
tell us about if you have the different sensor, you already can get the data from patient. Why can't you treat them patient? Why they have to come to your office? Why can't you treat their glucose from distance, remote patient monitoring?
yes, so they have to come to the office at least once in 3 to 4 months, because remember, we have to talk to the patient, we have to hold their hand, we have to examine them, and we have to look at all other disease processes. But if we are talking only about diabetes management and your health well safe remote patient monitoring app,
Your
that's
sugar
more
is
than
300,
enough.
and
Yes.
why they have to wait 3 months to see it?
Correct. That's why the app that you developed and with our desktop and all, it alerts me every day in the morning. Somebody with the low blood sugar or a very high blood sugar, we call them and we manage them, within no time. They don't have to wait too long. So these are all the patients, and on the right side you see, the last 2 patients, they're on continuous glucose monitoring systems. And this is the system that we use to take care of your nephew also. So, and nowadays you did a great thing in incorporating Dexcom into this health. That's it.
So these are the patients. So all our patients now, you don't have to go to different system. You just have one system which will get every patient of yours in this system, and then you can manage the diabetes or blood sugar every 3 days rather than every 3 months.
Correct. Yeah. So can we move forward? Okay. Yeah. So this is how it looks, and
this is complete system. Yeah, you can see you change the medication, you prescribe the medication, you can make a document, and then able to bill for your service.
Sure.
So
all in one setting.
from one place.
So you put in a lot of effort for this one. It's working pretty good. So, and
That's
you
a
can
report,
create a
yeah.
note also. You can create a report. So everything is documented, and I like it. I like it a lot. So, and so this is your nephew. See how high his sugars were, averaging 171 as per the Dexcom. Then once we started talking to them,
So you're
and
talking about
changing.
your patient in India.
Yes.
You watching him, and then what happened
Correct.
after remote patient monitoring.
Correct.
So you basically didn't even see him. You just
Yeah, I never seen him.
Yeah, remotely handle him.
Yes.
And did a great job.
So within
Thank
like
you.
2 weeks,
Thank
right?
you.
Look at the time in range, 97%. All we need is 70%, but he did so well. But I really appreciate, because the guy, he was very smart. He understood what is needed, and he took all our advice to the heart. Look at him, how good he's doing.
So if you're diabetic, you are a sensor, you're taking insulin, and you're not on remote patient monitoring, you need to talk to your doctor about that.
Correct. Yes. So my thing is, talk to your doctors, and they will point you in the right direction. Look for a good endocrinologist who is doing all these sensors and the pump technologies. So, good. Is it the last slide?
So let me ask you a few questions. I am the health ministry. America spent like $4 trillion in healthcare, and the costs keep going up.
Right.
And the reason keep going up because new technology we can keep adapting it. So we have sensor now, we have pump now, and we have remote patient monitoring. We can follow the patient. Now, if we have all this technology, are we really improving quality of life, or are we making them live longer, or decreasing complication, or just decreasing the hemoglobin 1AC?
Yes, so there are a lot of studies going on. Everybody's looking at this data, especially insurance companies. They want to know. But what Medicare has seen so far is by using the remote patient monitoring, they actually save money. That's why they are in the forefront of promoting remote patient monitoring, because they see the value in it. So are they going to live longer? Possibly. But at least we can say that, yes, you give me a patient with a blood sugar of 500, A1C of 15.5%, then I will use all these technologies. I will change his life. And within like 4 to 6 weeks' time, they do much better. Because the thing is, when the sugars are very high, it's a glucotoxic state. Patients don't feel well. Okay? And not only that, when the sugars are that high, they're more likely to have heart attacks and strokes.
So can you go back in time, like now? Can you think about this? How would you treat diabetes when you just have urine to test and have insulin?
We did reasonably good. We survived, all right? So, but now we are excited because we understand diabetes. We understand all the pathophysiological aspects of it. Now we know how to treat it. We can pinpoint all the different things that go wrong with the diabetes, and you can use, it's like having an armamentarium with so many arrows, right? The only question is, which patient, which intervention, which sensor, which pump? Do we have to use an SGLT2 receptor blocker or a GLP-1 analog? See, you can do so many things. So that's why we use common sense. We go step by step. Initially when you come to me, if you're in a decent control, I'll try to change your lifestyle. I'll put you on metformin. I'll put you on an SGLT2 receptor blocker, right? Then add a GLP-1 analog. Try to keep you away from insulin. But a certain percentage of patients, they're so insulin resistant, they need much higher dose of insulin. Those are the patients who need all this technology.
So, Dr. Baliga, you said you're diabetic patient like your children. So these bad children or children who don't follow your instruction or non-compliant, this technology has helped them?
Yes. So because sometimes, although we call them non-compliant patient, sometimes they think that, regardless of what they do, they're going to die. So now we give them a hope, saying that, hey, forget about the past. Let's turn a new leaf. Use this technology, control your diabetes better. I won't shout at you.
That's awesome.
Right.
Awesome.
Okay.
So, Chesko, do we have any question for our audience?
Okay.
Well, I think you have to go early too, so we're going to let you go. Thank you, everybody, to join this webinar. We believe that the time has come that all diabetic patients should be monitored remotely if they are poorly controlled and they are on insulin, and rather than seeing them every 3 months, you need to be monitored every 3 days. Would you agree with that?
Yes.
Okay. Thank you, Dr.
Thank you very
Baliga.
much. Appreciate it. All right. Bye.
Thank you for joining our webinar. Be sure to follow us at Health Wealth Safe on all social media platforms so you can stay up to date with new healthcare technology. If you have any questions, please email us at info.healthwealthsafe.com. And remember, your health is your greatest wealth, and we want to help you keep it safe.